Community members, welcome. My name is Antoine Craigwell, and I'm President and CEO of DBGM. DBGM is an organization that was founded to ensure that we raise awareness about mental health issues impacting Black gay men to prevent their suicides. This evening, we are going to be focusing on looking at and celebrating World AIDS Day. But as we celebrate World AIDS Day, we want to ask you to consider the different ways in which our communities have been impacted by the advances in HIV treatment, to consider shame and stigma continuing to exist, and what do we see for our Black gay community, and by extension, the LGBT people of color communities? What do we see as the future for HIV in our communities? So today, our program, I will introduce and welcome you all, and we will have a short memorial which we have compiled and we featured in this year's In My Mind conference. And it's a memorial that recognizes and acknowledges and brings into this environment, into this forum, community members who have died from HIV/AIDS, who have died from suicide, who've died from homicide, or been the victims of domestic violence between October last year to October this year. The music that we're going to hear was arranged and performed by students of the Juilliard. Following the memorial, I will introduce Vaughn Taylor-Akutagawa from GMAD, and then Larry Scott Walker from THRIVESS. And then I will show the trailer for the documentary You Are Not Alone, which raises and discusses a number of issues impacting Black gay men that can lead to or contribute to their depression and suicidal ideation and attempts. And then we will invite Doug Hill from GMHC to share with us about HIV in New York City and beyond. And then we will invite Kenyon Farrow to talk with us and share with us about crisis in HIV treatment, the crisis in HIV treatment financing, what it is, or some of the things that we need to know. So just to begin, we all know these little bits of etiquette and things that we need to do, because we've been doing online fora now for over a year. So just let's be kind of like mindful and respectful of others. So let's mute ourselves, let's chat responsibly, and let's really truly be participatory in this forum this evening.
Lift every voice and sing till earth and heaven
So community members, I'd like us to now take a moment to welcome Vaughn Taylor-Akutagawa, who's the Executive Director of Gay Men of African Descent, GMAD. And it's an organization that is dedicated and experienced social activist and architect. He is a dedicated and experienced social activist and architect, entrepreneur, and community researcher. With his education and experience, Vaughn worked in medical performance publishing and social entrepreneurship. As a social services professional with more than 25 years of experience, he conducted workshops and provided attendees with practical insights into various cultural and ethnic groups that form the basis of contemporary American society. So community members, I'd like us to welcome Vaughn. Vaughn, are you there?
Yes, can you hear me?
Yes, welcome. So,
thank you.
Vaughn, like I said, thank you very much for joining us and for representing GMAD, one of the oldest Black gay organizations in the country, whose founding was based on the disproportionate attention to Black gay men who were severely impacted and devastated by the new gay virus. Based on GMAD's history working with Black gay men and LGBT people of color communities at large, share with us what you witness as the trajectory of HIV treatment, access, and care for Black gay men, and where our communities are today in this continuing pandemic.
Sure, very important position, and thank you so much for the opportunity. On June 5th, 1981, Centers for Disease Control discovered this new infection that was impacting a small subpopulation of American society. We've not yet recovered from that particular perspective on how actually we get better. When it comes to the breadth of American history and looking at Black and brown people, the country has always had an interesting set of ideas and rules to control Black bodies. That has never been more evident than the country's response to HIV. Currently, we've had incredible success in making HIV perceived to be a manageable disease. We have an injectable called Canuba, which people can take once a month and not worry about swallowing pills. We have the opportunity to have people who are HIV negative take meds to keep them from acquiring new HIV infection. We have ideas around treatment that look at the whole person. The challenge comes when it comes to Black gay men. We don't have access. So all the treatment cascades, all the great treatment possibilities mean nothing if you cannot get someone to have access to treatment and keep them in treatment long enough to benefit. We want to make sure that everybody living with HIV understands there's an opportunity to address your medical illness in an effective way, have wraparound services for you, and stay in those systems longer. Depending on where you live, that's not an option. Here in the Northeast, we have some of the highest numbers of people living with HIV recorded in the modern world. If you live in Atlanta, for an example, you live in third world conditions. We have to be able to link those disparities. The trajectory of HIV has been, said earlier, a study of medical apartheid. The laws that look to control Black and brown bodies have always been consistent that we're important enough to be studied, but hardly important enough to be included in care and treatment profiles. If you live in Atlanta, you can have a one-way trip that's 2.5 hours to get to effective care and treatment. And if you miss one bus or one train, you're not getting served that day. Here in New York, we have tons of options of treatment, but not often supportive ancillary services for your mental health, substance abuse, and mental hygiene. We never actually think about the unique intersectionality of Black gay men and what it takes to get care and treatment. We don't talk enough about the tiers of socioeconomic status and the levels of stigma that are provided in being a Black gay man. Example of the trajectory of our experiences has been. Back in the mid 90s, when Bill Clinton was president, there was an opportunity for 27 advocates to go to the White House and talk about effective funding for us. At the time in that room, Secretary Shalala said very clearly, we won't be able to get legislation through, get effective funding, if we openly talk about gay men. The people in the room advocated effectively and said, we won't use the term gay men. We use a behavioral term, men who have sex with men. And Black gay men took a step back to be more inclusive for women and children. And as a result, our HIV numbers exploded. In 2004, CDC came up with an idea to address the epidemic, advancing HIV prevention, and focused on prevention with positives. I was one of the few people that stood up and said, this may not be the best idea because it puts the burden of disclosure and containment of the disease on the most vulnerable people, which Black gay men and women of trans experience. We fast forward to 2015, CDC does another long-term study of HIV infections, confirmed once again, Black men are 7% of the US population, yet surprisingly, Black gay men are 49% of new infections. We paid the price. There's never been an equitable time to talk about what effective, proper funding levels would look like for us, what services should look like for us, and how to actually have a long-term inclusive conversation on reaching Black gay men in a way that speaks to their dignity, their respect, and their wellness. We have conversations around prevention and care that never quite connect. On one hand, we say, we want you to be and stay HIV negative, but if you seroconvert, it's okay. We never talk about the things that Black men need to feel comfort and supported in the conversation. The HIV numbers explode in our community repeatedly, and we never seem to quite get the full conversation on how to address our internalized stigma. As I sit here today, I'm reminded of a particular point of stigma that hit home for me a few years ago. There was a case in Atlanta where a gentleman went to visit his girlfriend. At his girlfriend's house, he saw his girlfriend's son and his presumed partner laying in bed together. The stigma on HIV being non-heterosexual was so strong, this gentleman decided to boil a pot of water and throw it on those two young men. So even what it states is that even when we get to this space where we can bring dignity and respect to services, get people to be encouraged and honest about their healthcare, get them engaged and disclose about their status, that they're living, not dying, that there are effective treatments. The response from our community is such a fear-based one that this gentleman decided, hey, you're sleeping together, I'm gonna throw water on you. They were in the hospital for 4 to 6 months with their injuries. We need to do a better job of saying it's okay to be men, give men a larger range of expression, and particularly make sure that agents like mine, efforts like this, talk about the total man. What does it mean to be Black, gay, and proud? To give men a wider range of emotional expression, and to be inclusive in what does it mean to get HIV services in your neighborhood? Not to be ashamed to take a medicine or pill and be safe, and actually be able to teach the science. One of the great things we've done in the industry is to bring up the ideas of PrEP, which is you can take a pill with 2 medicines used to treat HIV, to prevention requiring HIV, to treatment as prevention, and the advertisement of U equals U, which is undetectable equals untransmissible. That U equals U speaks directly to a sex-positive response to HIV. That is not a risk, a life-threatening threat, if you are informed, have good effective communication and services, and are able to actually help men be comfortable with who they are. We can talk about issues around the spectrum of gender fluidity and expression as a way to helping men to connect to HIV. But one of the consistent drivers of HIV in our community is a level of discretion of secrecy men feel they have to go through simply to say, this is who I am, this is who I love, or these are some activities I engage in without negative impact from the rest of the community. I'm just kind of stop there because there's a lot of data I could push forward, but we're still disproportionately impacted by HIV. We have effective care systems to treat HIV. The challenge is there aren't any inclusive models that put Black men at the center, that support us from beginning to end, to get into the system, to get on treatment, to stay on treatment long enough to see the benefit of a suppressed viral load. Thank you. As ended my remarks, I want to leave time for questions at the end.
Thank you very much, Vaughn. Thank you very much for that, for sharing that. And I'm sure that, I'm thinking that there may be people who might have questions. So I would ask you to please put your questions in the chat box, and we will save the questions for the end. I'd like to go back to, I just go to sharing my screen again. So our next presenter, we'd like to welcome Larry Scott Walker. Larry Scott Walker is the Executive Director of THRIVESS Support Services, Inc. and co-founder of Larry Scott Walker. He is a self-professed love poet trapped in an advocate's body. A Baltimore native, he is an author, artist, and advocate for equity and empowerment for Black, same-gender loving SGL men. Larry worked in the public health and social services arena for 15 years. He found his passion for community while as a student at Morehouse College in Atlanta, Georgia, where he co-founded the institution's first and only gay-straight alliance, Safe Space. After college, with his passion for community, he worked with community-based and aid service organizations, ASOs, before co-founding Transforming HIV Resentments into Victories Everlasting Support Services, or THRIVESS, Inc. Community members, I'd like us now to welcome Larry Scott Walker. Larry, how you doing?
Thank you for that, Antoine. How are you?
Good. So I have a question for you. Okay. And I'd like to first of all thank you for joining us and being willing to share with us your HIV work in and for Southern states with your organization. Drawing on the knowledge you amassed and looking at the landscape in the South against the backdrop of reports of rising HIV and other STD numbers impacting Black gay men, how and in what ways is this community, and by extension, LGBT people of color communities, impacted by HIV? How are they able to access treatment and care? And what do you envision as a future? What is missing? What's needed to effect better HIV attention and care for Black gay men?
Okay, thank you for that question. I think that actually Vaughn's presentation that I really enjoyed, by the way, answers a lot of that. Currently, in different areas, the response, the provision of care is disparate, So as Vaughn pointed out, in some areas like New York City or California, you may have like an abundance of places where people can get and receive care. I myself live in East Point, Georgia, which is right outside of Atlanta, Georgia. There's a lot of, places providing care, or more places providing care than some of the more rural lying spaces. I think that Vaughn also pointed out that a system of care provision must be designed that centers Black gay men and queer people. From beginning to end, that supports our whole existence and not just a single issue like silo, HIV, like what's happening inside of my blood, but my whole life and that intersectional life of as a person who's living with HIV, but also as a person who's Black, a person who's queer, a person who was born on the East Coast and raised poor, and because all of those things matter as it relates to my ability and even my desire to take care of myself, Antoine. So that's to answer that question. Should I go into the?
Yes.
All right,
Please.
cool, perfect. Thank you again for having me. And reading my bio. So weird to hear my bio read back to me. I wanted to start, and greetings, family. I wanted to invite you all into the chat box. I'm a person who likes to be in a room full of people. I get energy from people. So if you have any questions or insights to add to this presentation, please add them within the space. I was asked to come here to conceptualize what HIV is looking like for Black gay men in the South. And initially I started to tap into my bag as a person who likes to communicate and to think about like, okay, so what is my impression? How do I feel about this? But I thought it most important for me to start with the facts so that we can have a full conversation and you can develop your own assessment of what HIV looks like in the South and even to come up with correctives. So currently, 1.2 million people live with HIV in the country. And of that 1.2 million people, 13% of those people don't know that they're living with HIV. That's 1 in 8 people living with HIV are unaware of their status, right? And of the 86% of people who are diagnosed with HIV, a mere 66% of those people have received any form of care. That's gone to the doctor one time to be seen. And 50% of those people actually retained what we would say call retained into care is like, you know, you've gone to the doctor a couple of times, within that last 90 days, you've gotten your meds and things of that nature. And as Vaughn spoke so eloquently to, viral suppression or becoming undetectable as a person living with HIV is the goal, right? Because we understand, as it was proven by the partner study in 2014 and later affirmed by the U equals U campaign, which is undetectable equals untransmittable. When I, as a person, reach and sustain viral suppression, I can no longer pass the virus on to my partner. Well, only 50% of people living with HIV are completely virally suppressed. That leads to on average of 35,000 people in 2019, to be exact. There was 34,800 people who actually seroconverted or became newly diagnosed within that year. Okay, so of that number, 25% of that were white people. The local majority, the global minority, to be clear, the local majority. 29% of those people were Latinx or from the Latin community. And 41% of those diagnosed in 2019 were from the Black community. And if you know, the Black community, as we all should at this point, represents 13% of our country's population. As Vaughn has spoken eloquently too, this is a travesty. You know, so how could the minority of a population bear the brunt of the majority of the brunt of an epidemic that we've been facing for years? In addition, more information so that we can continue to build our concepts or analysis around where we are. You know, Vaughn did a great job at introducing this to the toolkit. We have a toolkits for both prevention as well as treatment. So in the treatment toolkit, you have pills that are getting smaller, less toxic to our bodies. You know, we could take these pills. There's pills that are longer acting that are coming out. You have injectables, infusions, and all of these amazing things, right? And in the prevention toolkit, we have PrEP, which is pre-exposure prophylaxis, which is either a pill that you could take every day that would stop the acquisition of HIV for people not living with HIV. PrEP is also about to be offered in an injectable format. There's PEP, post-exposure prophylaxis. There's syringe exchange. There's a bunch, right? But still, 34,800 people seroconverted or became people living with HIV in 2019. We have to ask ourselves, as Vaughn was, presented, why is this the case? And we'll get into that, but I want to put out some more of what we have going for us. We laid some more of the groundwork for HIV. So in addition to this toolkit and these approaches and modalities, we have the Ending the HIV Epidemic plan, right? So the Ending the HIV Epidemic plan is the effect of a lot of advocacy, let's just be real, on the behalf of people like the people that are on this call. It came out of the last administration, which, you know, that was headed up by Voldemort, he who shall remain nameless in this space, we will not. And it's the one good thing. And it's a robust plan, right? It has 4 pillars, 3 I really gel with. 1, I'm kind of like, it could be made better, but I'm here to deliver to you, my most trusted family and colleagues, the information, right? So there's 4 pillars. There's test, get the people tested for HIV, so that those 13% of people who don't know that they're living with HIV can, you know, become aware of their statuses and act. There's treat. So getting people on effective treatments, diversifying treatments so that we can really manage and operationalize treatment as prevention for people living with HIV so that we can all become undetectable or as close to it as possible, right? And then there's prevention, like we talked about, prevent, you know, there's the monies that are being placed into not only PEP and PrEP and these biomedical interventions, but also like behavioral interventions and things like that, to understand that like prevention is power, like we can prevent people ever having to live with HIV. And then there's a respond pillar. This is the pillar that I want to invite all of you to look up in your own time, because this isn't the part of the presentation where I give you my feeling. So the respond pillar is, you know, utilizes molecular surveillance, utilizes the biomarkers of people living with HIV to detect clusters of other people living with HIV so that they can respond in a myriad of ways. So this process is being forwarded by people like Justin Smith, my closely Justin Smith, who is the director of HIV elimination at Positive Impact Health Centers here in Atlanta. Minds like Kenyon Farrow, Greg Ladd, and all of these very just powerful minds, you know? So this is the full understanding of, if you will, of what is in our toolkit. And now we're at the reality. 34,800 people seroconverted in 2019. And though I believe firmly in the ending the epidemic plan and its aims that we'll get into a bit more in depth in a second, there are some very clear reasons that Vaughn spoke to as to why we continue to see these rises in new cases. First off, mine, and this is not an extensive list, this is where I'm inviting you into the chat box. Come on, jump in my DMs and let me know of your expertise. I want to glean of your expertise as well. But stigma, I would be remiss if I did not honor stigma as being one of the main and most pervasive reasons as to why we have this issue that we have. Vaughn so eloquently covered anti-Blackness, racism, the system of racism, not only chattel slavery, but the racism that we face every day as Black people. The fact that I can't even go to the Wendy's to get a sandwich without being accosted by cops, you know, and potentially killed, that relates to my ability to trust this system and my desire to take care of myself. Stigmas for trans people, as Vaughn also pointed out, and as we had a memorial in the beginning of this program, might the transphobia that we experience in this country from the policies that would challenge a trans person's ability to eliminate, to even use the bathroom, a basic inalienable right. Like, if I can't hold it, what you gonna hold it? You know, like why is this being up for debate? Might that challenge my ability or desire to enter into another system where I have to trust some of the same people who are challenging my personhood? When I think about the reality, we just had the Transgender Day of Remembrance, and I think about the reality of Black trans women in this country. And as we sit here in 2021, in one of the most deadly years for trans people, with 47 trans people being murdered this year, might that impede or impact a person of trans experiences' desire to enter in a space where they don't feel safe? So these stigmas, the homophobia, the ageism that we experience, the misinformation, in this backdrop of COVID-19 that has killed 700,000 plus of our family members and loved ones, to hear the misinformation around not only COVID-19 in our communities, but from the leadership Might this misinformation, this preponderance of misinformation in a system where, okay, I just contracted HIV and I don't want to live with, I don't want to deal with it. Might I be like tempted to believe that it's not a big deal? Or some of the other misinformation swimming in the space? Might that impact my decision-making? The fear, the false evidence appearing real, all of the stigmatizing things that we hear in our communities as people living with HIV. And I would be remiss if I did not hold up criminalization, the over-criminalization of certain bodies, over trans bodies, Black bodies, of people who are experiencing behavioral health conditions as bodies. You know, we exist in a world, in a space where it's so apt and is so thirsty to institutionalize us, to penalize us, to put us back into a system that when I'm being told that I have to engage Ryan White or some other governmental system, it gives me pause. The fact that there's HIV criminalization, the criminalization of people merely because there are people living with HIV who are engaging in pleasure. I remember when I first moved back to Atlanta in 2011, and I was signing up for care at a Ryan White clinic here in Atlanta. I was made to sign a piece of paper that stated I did understand and receive my positive diagnoses, even though I had been living with HIV for 3 years at that time. I was made to sign this paper, and it said that this paper could be used as proof that I knew my status. I knew what that meant. I knew that that meant that if I didn't, disclose my status, or that I could be penalized around my status. Do you think that that made me want, or that as a person who is being tested for HIV or should be tested for HIV, do you think that that would incentivize a person to want to get tested for HIV? It made me want to run up out of that building. When we think about these barriers, when we think about the lives of the intersectional lives, as Vaughn pointed out, of people living with HIV, more specifically Black gay men living with HIV and queer people in the South, we have to think about these barriers. We have to think about the lack of focus that's placed on our social determinants of health. And I know that we probably hear the social determinants of health so much that we're just like, okay, but it's true. If you see, we're impacted by what we see. We're impacted by whether or not we have a job. We're impacted by whether or not we have stable housing, how our government treats us, how the system, the laws that we operate under value or don't value our lives. And we can't ignore that. Anything other than sensitivity towards that, programming created around that is crap. And it's feeding back into a system of supposed bootstraps, where we're expected to just pull ourselves up by bootstraps that don't exist. So I wanted to give you all this information because I want to know what you feel like the state of HIV is right now. Yes, if you listen to some epidemiologists and you look at the data, yes, HIV is trending down. And when I first got into this work, it was some 50,000 people a year who contracted HIV. It's 2005 or so. 2019, 34,500. That's down, right? But when you look and when you disaggregate the data or look at the disaggregated race data, you see that if you look in Love Like Me, that ding, 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 your numbers are consistent. And if you're younger than me and you look in Love Like Me, that the numbers might be actually going up. So when we talk about this beautiful plan to end HIV and we look at the metric, and again, like I said, I feel like if we could really operationalize this and do what Vaughn said to support these community-driven processes that center people, that we can impact HIV. And the metric for the EHE is, to get down to reduce the number of new infection by 95%. That is amazing. 3,000 new infections a year. Kudos. But then I have to ask the question, who are those 3,000? How do they look? How do they love? Are they like me? Do they look like me? Do they love like me? I wanted to start with a poll. While you add your answers into this chat box, and I don't see that chat number going up, but I know it's coming, you know, where are we with HIV? I've given you the facts. I tried to take as much of Larry out of it and give you the numbers. Where are we with HIV? But before you put that, I have another ask. When you add your criticism, your assessment, your analysis, also add your answer. How are you addressing HIV in your local community? How? What is your answer? What are you contributing to the fight? And I'm not trying to call you in this weird way to make it seem like everybody has to be an executive director, because you don't. It could be as much as like moving policy, or as much as giving hugs and stopping the stigma when I hear it. But I need to see it. We need to see it, because we're not going to end HIV in our silos. But our efforts, our continued efforts to add to the addressing it will. So again, I look forward to seeing your answers and seeing your answers, as well as your analysis, and to answering your questions at the end. And as I have 4 more minutes, I was going to start with a poem. I'm going to end with a poem. The state of Georgia has placed a mandatory minimum on your right to choose. So if you've got it, you've got way more than just T cells to lose. You could end up on the news over an X with the blues, and before you get the chance to prove, the whole city and state knows your truths. I've told so much that I've become this disclosure artist. The heart is the hardest, most visceral piece of lead, and I'm surprised that I'm not dead already. And the worst part is that they say that 1 in 2 of us will get it. So if you never heard those words said already, son, you've tested positive on this INSTI test. And I'm gonna let you get them feelings off of your chest as soon as you sign on this dotted line that states that you understand our disclosure law. And of course, you can decline, but the law is still the law after all. I mean, and I feel bad for y'all, but nobody told you to be so, you know, carefree, gay. I understand that you were born this way, but it's your responsibility at the end of the day, okay? Broken bodies are being locked away in a place where CD4 cells has a different meaning. And being butch, queen, pretty makes you a target on this proverbial market. You become a number for a not so fresh meat for carnivores to eat. You become a number for as many as 30 summers. You become a new and different type of numb. You know, the one where the sensations never really return. And the little bit of feeling that you do have is like this consistent slow burn. Thank you all. Challenge HIV criminalization, and I look forward to your questions.
Thank you very much, Larry. That was extraordinary. I like that ending poem just now. It kind of summed up all of you were talking about just now. And what I think was particularly impressive about what you were saying just now is the numbers and the things that people have to struggle and deal with in southern states. And I guess perhaps we can try to think about how we would be able to address HIV for our brothers and our community members in the southern states. So once again, thank you very much, Larry, for sharing that. I'd like to move on now, just take a moment and share with you guys the documentary trailer.
Still in the closet about my homosexuality. I'm still trying to come to grips with being gay.
Being raised in the church, that was a big, big no-no.
The good books say a marriage is between a man and a woman.
What's wrong with you? Do you need to see somebody? Do you need help?
That was the one thing that severed any relationship that we ever could have.
I was promiscuous, and I stopped counting after 100. Hey, I'm my experience, if that's what you want to call it.
I was actually a college student at 19 dealing with HIV.
If I'm gonna die anyway, why am I fighting?
I just wasn't happy anymore with life or myself.
I think I was kind of forced into believing that this was just a part of life.
I guess I knew when I woke up in the hospital on a gurney, being wheeled into the emergency room after taking a handful of muscle relaxers. That was a clear sign that something was up. problem is in your head at the moment. So you gotta talk to other people. You've got to share what's going on inside.
You just kind of got to get over your homophobia.
You need to pray and ask for forgiveness.
It's not as simple as that.
Because often their voices have not been heard. Your voice is part of your body. It needs to be connected to who you are.
It's who we be. I don't do black, I be black. I don't do male, I be male. I don't do gay, I be gay.
This is you, and this is how God made you, and this is, I believe, how God has made me.
Talk about that pain being in an anti-gay and black world.
We are not meant to be inauthentic for very long.
So I don't have to be perfect being me. I just have to be me.
Well, what are you going to do on the last day of judgment? I said, I'm going to say to Allah, Allah, get you a big popcorn, a giant soda, and let the video roll.
Our next presenter is, I'd like to introduce Doug Hill, who, with a master's in social work from Fordham University, Doug Hill serves as the Senior Director of Aqueous Centers at GMHC. He manages and oversees programs including the National Resource Center on HIV and Aging, NRCHA, research activities, the HIV Health Literacy for Older Adults Program, Sudden Impact Project, the Healthy Aging Project, and the Condom Distribution Project. Douglas joined GMHC in 2018 as the Assistant Director of Youth Initiatives for the Love Heals program, where he worked with young people providing evidence-based, comprehensive sexual reproductive health education across the greater New York area. He brings with him more than 20 years experience in nonprofit, mental health, and social services. Doug's passion for his work extends outside of GMHC and is demonstrated through his partnerships with organizations and institutions like Boys to Men Counseling LLC and Morris Brown's College's Choice Program. So community members, I'd like to welcome, like I said, Doug Hill. Doug, we have to thank your colleague, Krishna Stone, for assisting with facilitating you being able to join us. And again, thank you for your willingness and availability. You represent one of the preeminent HIV organizations in the country. Acknowledging GMHC's history and work in HIV, would you share with us how your organization continues the fight against HIV, especially as it impacts Black gay men and by extension, LGBTQ plus people of color? And as a corollary, the attendant shame, stigma, and discrimination which seems to be present. What are some of the successes, failures, and stubborn challenges that impact HIV treatment, access, and means of eliminating it? Community members, Doug Hill.
Good evening, everyone, and thank you. It's been a pleasure to sit here with you all and learn and listen from my colleagues. So just to give you a little background on GMHC, it was started in 1982 as the first agency to address HIV to ever exist. And how it was started was a few men in a living room got together to address the AIDS cancer. Back then it was the gay cancer, right? They called it the gay cancer. And so the program, the agency just was born from that need and that care, and little by little it started to grow. Fast forward, we're in 40 years into this pandemic, and the services where we started with an answering machine, just taking calls from people living with HIV and just gauging what the need were from the community members impacted by HIV, to beginning a program, a long-term buddy program, where people would just help, you know, and be there with people, because in the beginning of this epidemic, people were dying. They were being diagnosed with AIDS. It wasn't an HIV diagnosis, it was pretty much an AIDS diagnosis when people were coming up testing positive. So since then, the agency has began to offer services like advocacy, health benefits, testing, housing and financial management, legal services, meals and nutrition, mental health and behavioral health services, substance use services, trainings, educations, capacity building, research, wellness program, workforce development. So GMHC tries to, I think we've had the opportunity to gather a lot of information because we've been at this work for so long. And so what we do is we learn what the need is from youth all the way into adulthood. And we cater our services and programs around that. I think that Larry and Vaughn both talked about the need to kind of really engage community members and find out what works or what doesn't work. And I think that GMHC has a cohort of experts that have been in this field doing this work for so long that what we like to do, aside from gathering data, we like to identify these barriers and obstacles that people are facing when we come in contact with our clients and community members and begin breaking them down, right? And Larry talked a little bit about performance measures and just different ways of kind of figuring out from the members that we serve, what works best for them. What are the obstacles? Who better to tell you but the members themselves? Through their experiences, through going to healthcare, going through public welfare offices, accessing services, accessing medical, accessing treatment. So GMHC, one of the big things that I think, the first thing I wanted to ask was how many medical providers do we have here on this call? Are there any doctors or hospitals being represented on this call? Because that's one of the things that we are hearing and seeing that still is a continued challenge, right? Doctors and medical providers are still not educated and trained around HIV today. Right? They may have gotten that information back in the beginning of this epidemic and gone through their training, but today things will look a little different. And how do you engage people not only to test and to have the conversation, begin the conversation around their sexual reproductive health, but how do you bring up topics with your clients, whether it be a man who has sex with men or a trans person? How does that translate into the healthcare, into the services that we would provide from our medical providers? And why are they not here, right? Why are they not part of this conversation? I think that's something that we're still challenged with. I know that a lot of work that we do is training and capacity building, not just with community members and other agencies, but with medical providers as well. Because conversations we're learning that are still not happening around PrEP and PEP, around prevention methods. And a lot of times what we're hearing also and learning is that these experiences can also push people away, deter them from accessing services. So we do a lot of work around language, learning new languages, perfecting new language, helping people, engage in these languages because sometimes there's a lot of resistance. I know that pronouns has been a topic for many years for some people, and that's still a challenge, right? And so we do a lot of work around that. It's just so much that GMHC does, along with the partnerships that we engage in with you all and different members in the community, the North, the South, the East. We've learned to kind of just offer support wherever we need, and different organizations and different locations are not always having the same information. So we do a lot of sharing of information with other organizations and teaming up to kind of provide services that are limited in other parts of the country, in other parts of the city, in other parts of, even in the world. Some of the services that we provide, like long-term survivor support groups, we have people that are engaged all the way from Puerto Rico, from Hawaii, So we're learning that these services are still not available widely, nationally, and even internationally. So we try to see how we can bridge that gap and provide those services on a wider scale. And so that's the work that we're doing.
Thank you very much, Doug. I'm also interested that to welcome into our space. I saw that a couple of people I know from Nigeria have joined us, and I know it's like maybe close to midnight or early in the morning in Nigeria. I know that there's somebody from Jamaica here. Those are two particular countries where being LGBT is criminalized, and there's issues also with HIV in both of those countries. So I'm really glad that Doug just talked about the international component to GMHC's work, and I'm so glad that we're able to have a couple of people here from Nigeria and somebody from Jamaica, and I'm not sure if there's anybody else from anywhere else in the world. So our next presenter is somebody that I have known for quite a few years, but I'd like to introduce my dear friend Kenyon. Kenyon Farrow is a writer, editor, and strategist whose work has long focused on public health and infectious disease with a focus on racial, gender, and economic justice. He's the managing director of advocacy and organizing with Prep for All. He serves on the board of Global Black Gay Men Connect, the LGBT Center of Greater Cleveland, and the New York Transgender Advocacy Group, NITAD. Kenyon is a prolific essayist and author. He is a contributor to the new anthology Abolition for the People, edited by Colin Kaepernick, and his essays in a dozen other books and 100 published articles in many news outlets. So community members, I'd like us to welcome Kenyon. And I have a question for Kenyon that is what I think brings him to join us this evening. So Kenyon, thank you again for your willingness and availability to join us for this discussion. We are grateful that Mark King, who recently published the article in Pause, and which subject you'll be addressing, recommended you as a subject expert to speak on the changes in HIV treatment funding or financing and how these will impact our communities locally, regionally, nationally. What are these planned changes and how will they impact the average Black gay man living with HIV? So Kenyon, over to you.
Thank you so much, Antoine, and thank you to all the folks who are attending and to my co-panelists. So I'm going to be the one person with a slide deck, and I generally do not like to use slide decks, but because this issue is pretty technical, I'm going to try to explain it in as kind of clear and plain language as possible. But it, will be helpful, I think, for people to see some, images as I talk about what's happening. So as was mentioned, the subject of this is the crisis in HIV prevention and treatment financing. Essentially, how do we pay for treatment and PrEP services? And some of the things that you may have heard about in the news over the last roughly 6 months, in addition to the piece that I just dropped in the chat that Mark King wrote, I think really kind of calling the community to action to really deal with some of these issues. And a lot of what I'm going to talk about is particularly the kind of 340B program, and I'll explain that, talk about what that program does, its relationship to, kind of HIV treatment, and how we finance many of our community organizations that provide medical services for people living with HIV. What some changes in Gilead Sciences, kind of patient assistance program called Advanced Access, and the relationship between that and 340B, and what those things are kind of doing right now to put a lot of our programs in jeopardy, especially when we're talking about the South and in non-Medicaid expansion states. And so I'm sorry for my folks who are attending from outside the United States. There's going to be a lot of U.S. health policy, but it may be useful in other ways. So to talk about the 340B program, so it was signed into law by President George H.W. Bush in '92 as part of the Veterans Healthcare Act of '92. And you think about it just in the kind of sequence of time, this is 2 years after the first passage of the Ryan White Care Act, which is partly why these things kind of work in tandem, because it's 2 years before the Ryan White Care Act is passed, and then about maybe 3-4 years before, antiretroviral medications really begin to enter into, the market as they were, developed in the mid 1990s. So what 340B does is it allows federally qualified healthcare clinics and what are called FQHC lookalike clinics, as well as public hospitals. All these kinds of groups are called eligible entities or covered entities to access drugs at a discounted price. And basically what that does, so it gives those organizations the ability, because they're serving, so to be an FQHC, you are a designated medical facility that's serving kind of underserved populations, as the language is. And so you're, the folks who are reaching a lot of, folks living with HIV, and the kinds of clinics that are in, Black and brown communities around the United States. And so those clinics, providing those services then are able to, through the federal government, through this program, if they have to prescribe sort of high cost medications to their patients, in our case for HIV, but it could be cancer drugs, it can be some other kinds of medications, for providing that care to underserved and sometimes uninsured populations. They get a kind of rebate. They are able to buy those drugs at a discounted price, but they also get a rebate, which is per prescription, which creates, kind of an economic, a part of the budget that a lot of the organizations are able to operate under. And I'll explain that in a second, kind of how that works. So using this graph, the manufacturer, the drug company provides, the hospital or the clinic with the discount drug. And as you see here, this gives a kind of an example of like how the money sort of gets, broken down. So the, insurer, pays for or negotiates a price for that drug. And then the clinic keeps a profit, right, from that. So in this case, they sort of use $100 reimbursement for the drug from the insurance company. The 340B purchase price is $60 of that $100. The patient pays $10, $10 copay, for example, and then the balance of that copay minus the 340B rebate, the discount price, that $50 is what the clinic or the FQHC gets to keep, right, per prescription, right, per month in the case, right, of HIV. So that's, sort of how it functions. Another way to look at it, right, so this is looking at sort of two different patients, one that's insured, one that's uninsured, who go through hospital. For the insured person up top, that covers, they go, they get treatment, the hospital allows that 340B for the prescription that they get a rebate for that. But the way the hospital, again, so if the hospital or the clinic is getting a rebate for that, they can then use those resources to provide care to uninsured folks, right? So that's part of, the incentive for, federally qualified health centers and FQHC lookalikes to provide care to people who are uninsured or et cetera. So one of the things that the 340B program sort of prohibits is what we call double dipping. So if you are a 340B, receiving 340B, rebates for prescriptions, it prevents you from getting a discount through that and the Medicaid drug rebate program, right? So, so it creates a situation where it, is keeping institutions from double dipping. Now, this is the first part is the most technical part. Then I'll get into like what all this means, like what is the impact of all this. So to look at 340B, right? So just explain that part of the system, but then we also have patient assistance programs, right? So the drug companies also provide, so it's like the drug manufacturer provides some money to people prescribed, their drugs who would otherwise not be able to afford them, right? So even if you have insurance or whatever, and your copay is so high, your out-of-pocket expense, there's for certain drugs, drug companies offer these patient assistance programs to give you some money towards your out-of-pocket costs. And also for, again, these kind of FQ, federally qualified health centers and other clinics, they're able to get the 340B rebate and sometimes get a rebate from the drug company for the prescription through the patient assistance program. So that part is legal. It's kind of a loophole in the law that I just referred to previously that, bars them from double dipping in like, Medicare, program, rebate programs. So part of what happened to create the crisis that we're in, which I'll describe more in a second, is in 2020, so a year ago, December 14, 2020, the Government Accountability Office released this report basically saying that there's a lot of abuse in the 340B program by, hospitals and clinics, right? So that, they fail to maintain eligibility-related requirements. They sometimes divert 340B medications to ineligible patients. And then they sometimes double dip, right? Which I described was illegal in terms of doing that with the Medicaid rebate. So as a result of that report, this past spring, Gilead Sciences announced a change to their patient assistance program to kind of close the loop on that kind of double dipping with the patient assistance program in 340B. And so what they announced in their press release was that they would allow patients to choose to have their prescriptions filled by a mail order pharmacy or a retail pharmacy, which means that those clinics cannot, a lot of those clinics, as many of us know, have their pharmacies attached to them. And so this means that rebate money does not then go back to the pharmacy that's attached to the clinic. It goes to another entity, right? So that's a loss of resource for the clinics, right? And then they also said that covered entities, meaning the clinics and hospitals, would only be reimbursed for the amount paid for each bottle of a prescription, plus a dispensing fee and administrative fee. And what they said in the quote, and this is a quote, this new model ensures that dispensing free medicine to eligible patient assistance program or medicine assistance programs participants will continue to result in no cost to the pharmacy and compensates pharmacies for dispensing the free Gilead medication. Right, so that was their kind of reason for changing this. Now, initially, this change, they announced it in April, was supposed to go into effect in October. And a lot of community-based organizations and FQHCs that provide medical services to people living with HIV flipped out, right? Because it was in 4 months, they were going to have to figure out a whole new financing structure to pay for services largely for people who are uninsured. So because of some community advocacy, and some bad press, frankly, they pushed it back to January 1, which is still not a lot of time for organizations to have to figure this out. So we're coming up very soon on a cliff, which I'll describe more in detail, kind of like putting all this together. So now turning away from like the real, kind of geeky healthcare policy stuff, let's talk about what the impact of what this means, right? So this newly released data yesterday from the White House Office of National AIDS Policy, looking at new infections among most impacted populations in the United States, right? And we still see that Black, gay, and bisexual men in 2015 and in 2019 still ranked the highest in terms of new diagnoses of HIV. And when you consider the size of our population, if Black people are only about 13% of the US population, and then Black gay men being an even more smaller proportion of that, for us to have more raw numbers of HIV diagnoses, not even percentage, just actual numbers, more than other groups is astounding, right? So this is, part of, the deal. So again, to talk about disparities, right? HIV rates highest among Black trans folks, whether trans men or trans women, when you look at trans data, right? So again, who does this potential loss of infrastructure, really impact? When you then look at the kind of HIV burden across the country, given the federal sort of in the epidemic plan that was launched, I believe 3 years ago, of the 48 highest burden counties that are targeted in the initiative, and also 5 whole states, I think in that initiative, 48% of those are in the South, right? And we know that the South is still in this country where the vast majority of Black people live. It's also the vast majority of where new HIV diagnoses are. And on the adjacent slide, this slide is showing viral suppression rates. And again, we see that the lighter blue states have the least viral suppression. A lot of them, the deep South states, where there's also, some of the highest HIV burden. So also when we look at PrEP access, right, this similar dynamics in terms of most of the 48 counties in the HIV epidemic plan fall in the South for high unmet need for PrEP access, right? So again, seeing those disparities. Some of the problems with the 340B in terms of like this system of care and financing. So one, it's a tiny amount of money, but it means a lot to those small organizations. But when you look overall, it's only about $6 billion in revenue. It also perversely incentivizes the use of more expensive drugs, right? So we're in a situation where most of our HIV care is paid for by high drug costs. And I'll talk a little bit more about why that is problematic, in a second. But each eligible clinic's revenue is explicitly dependent on using the most expensive drugs, right? And using generic drugs dramatically decreases the revenue. And as we all know, this year PrEP really went generic, right? So we now have generic Truvada, which instead of going for roughly $1,800 for a 30-day course of medication is now costing about $40, right, for some of the generic manufacturers. And so while that's good for patients and for overall kind of public health spending, it's a loss in revenue, right? If we think about the 340B program for those clinics. Some other kind of things, like what does this all mean? So why is this a crisis? So if we consider the fact that Gilead alone making this policy change in their patient assistance program, the way in which that got so much revenue from the federally qualified health centers and community clinics that provide medical services to people living with HIV, Gilead's drugs for treatment alone make up 57% of all antiretroviral use in the United States. So that's a huge portion. So we know that there are other, medications that people can take to treat HIV, but Gilead's market share is so large that it's a huge loss in revenue for those organizations waiting for those rebates. Medical providers that provide HIV medical care are going to lose revenue, as I just stated. Many organizations, again, use those 340B and advanced access dollars to pay for uninsured services. And when we consider, I think I accidentally skipped a slide, but I think most of us know that the states that haven't expanded Medicaid are also the states that have the highest rates of uninsured people, right? So many of those organizations in non-Medicaid expansion states are saying that they're going to have to stop providing PrEP services to uninsured people come January 1st, right? And so that's going to be a big disaster, right? One of the other things kind of complicating this system for the last 25 years of the introduction of antiretroviral therapy, we've had such great innovation. So we're constantly developing new classes of drugs, which were all new brand name drugs. And that is now drying up. We don't have as many new drugs, in the pipeline. And so we can't just keep churning people from brand name drug to brand name drug, to funnel, the 340B revenue into the system for care, because I think increasingly we're going to be starting to begin to see HIV drugs for treatment and not just PrEP go generic in the next several years, with fewer brand name drugs, in the pipeline. And that's going to be, again, a kind of long-term loss of revenue. And again, the introduction of generic PrEP, those generics, once they become cheap, provide such a little rebate value that they're problematic. Descovy, the other brand name drug approved for PrEP, goes generic in 2025, right? So we only got about 3 more years before even that drug is generic. And also, too, there's so much public pressure right now from everybody in America, really across all political spectrums, to do something about drug pricing. And so there are a couple bills, as the HR 3 bill, which has kind of been put into the Build Back Better plan, which is supposed to do some things to address drug pricing. So these things are moving that are going to reform probably the 340B program long-term. Congress has wanted to do that for a while. And then we're going to have some other impacts on drug pricing. So in closing, some possible avenues for long-term solutions, right? So one, we're going to have to really rethink and overhaul the way our financing system for prevention and treatment that doesn't rely on high-cost drugs in order to make the whole thing work. That writing actually, frankly, has been on the wall for a very long time. The one thing that we've been doing at PrEP for All, which I think we're now just got a letter from CDC this week that I think we're going to be successful in, is getting CDC to allow their grantees to use money for PrEP services, which they were not allowed to do before. So now if organizations can actually use some money that they get from CDC for prevention to basically pay for certain PrEP services, that will help fill some of the gap. We also have a paper about creating a national PrEP access program. We're going to update that paper for next year based on some new things happening, but you can check it out at our website. And also, we just need to prepare for a world where generic antiretrovirals are a reality, and how that is going to really transform the financing for healthcare for people living with HIV and for prevention. And then again, the cost savings of generics to support programs, is something that the federal government can do, is basically like take the balance of what, prescribing a generic drug versus the balance of a brand name drug, and actually just capture those resources as cost savings and then redirect it back into treatment and care programs is a possibility, right? And then also transforming, this has been talked about since the Affordable Care Act, but government really transforming, instead of pay fee-for-service kind of healthcare, and thinking about, even in terms of HIV, what it means to create value-based care so that we're paying for and incentivizing viral suppression, PrEP adherence, and other things, as opposed to incentivizing prescriptions, right? Which is kind of how it works now. So that is, that's the deal. And I'll shut up now and we can open it up for questions from me and from my other co-panelists. Thank you.
Thank you very much, Kenyon. That was truly informative, and it's exactly what I was looking forward to hearing from you about the subject on the 340B, because that article that Mark King wrote, that you put in a link in the chat, is truly scary for a lot of agencies and a lot of our community members who depend on services from these agencies. And if the funding is going to be cut, then how are they going to be impacted? There is a question here from one person who asks, what about those patients who have allergic reactions and other adverse side effects from these new medications, especially if they're not using people of color in their research or medical drug trials? So that might be something you might be able to respond to, Kenyon.
Thank you. So I'll say first, there, especially where PrEP is concerned, there are some sort of moves to, because some people, do have some, adverse reactions to, Truvada or even the generic, TDF, FTC, the two drugs that are in Truvada on the generic form. And so there are some people that, the brand name Descovy may be better for. Increasingly, insurance companies are asking for basically letters from your doctor because this is what happened. I've been on PrEP since 2015. When Descovy became approved for PrEP, my doctor switched me immediately from Truvada to Descovy. And so I was on Descovy for a few months until my insurance company said, "Oh no, honey, you have to justify why you need to be on this drug that's $1,800 a month versus like what is now generic and it's $40 a month." And I was like, I haven't had any of the adverse event, to Truvada. So like, I'll take the generic. So I just let them switch me back to generic just fine. So there are ways around that. And to the question about like, folks of color in medical research, I mean, I think at this point, HIV actually does better than a lot of places in terms of research, frankly, because a lot of the drug trials happen in Africa, or at least have a lot of large clinical trial enrollment in Africa, because that is, one of the parts of the world that has high HIV burdens. So we actually, in terms of HIV medications, generally, if we're talking about like race, get good data at this point around like Black folks, and then even in the like United States, like even some of the PrEP trials and stuff, like if we're like 10 to we're like 13% of the population. Some of these trials are enrolling at about 10 to 15. Some enroll at like 20%, like Black folks in the trial, which given our population in the United States is actually not bad. So honestly, I will say, of all of my critiques of medical research and range of things, where HIV is concerned, at this point, it wasn't true at the beginning of the drug development, but at this point, almost all of the drugs, whether prevention or treatment, particularly because they have so many clinical trial sites in Africa, we actually get a lot of data, looking at race.
Thanks, Kenyon. So let me just put this question then, and you could probably answer, but I also want to throw it to Larry and to Vaughn, who have been on the ground in terms of real actual community-based organizations. How do you then see this 340 impacting community members on the ground? What is going to happen for providing HIV treatment for community members, particularly in the southern states where Larry is located? How is this going to be able to affect our community members?
Well, I mean, I can say that the change in advancing access and 340B has definitely been like a jarring thing for people who know how their meds are being paid for. Some people, like, I think Kenyon spoke to this, where, some care providers try to get people onto Descovy so that they can continue to get, this. And, a lot of our members, as we have the largest network of Black gay men living with HIV in the country, we're kind of like, why am I being changed right now? Why is this happening? I feel like that in and of itself is just like a barrier, what I mean? Like not really giving people the full information just because, because it doesn't necessarily benefit you. I feel like that's a barrier. I haven't heard many people suffering, because of the changes of 340B. A lot of the organizations are bracing for, for this change because it's major. What I mean? At one point, you're bringing in like, upwards of $30,000 a month, and all of a sudden you're not. So, and a lot of the services that they were offering to their constituencies were based on these money. So, but yeah, so that's my take.
Thank you. Vaughn, you have any thoughts you want to share on how this is likely to impact our Black gay community here in New York City?
Sure. Here in New York City, it's probably going to show a substantive slowdown. Many of the larger institutions who rely on this offer incentives from the money they get. So for the lower income clients, they'll get deodorant, soap, bus tokens, etc. Since the organization won't have as many resources to provide, those resources may go away. It's also going to ramp up a numbers game for competition. Small and mid-sized organizations are going to be struggling and competing directly for numbers. The negative impact on the community will be there'll be less community education around what happens to your body, why it's important. There'll be less conversations around side effects management and mitigation for clients. And so there'll be a lot of confusion. One thing I was looking forward to hearing more about that will have impact with 340B is the role of non-prescription or on-the-corner drugs in conjunction with HIV medication use. There's very little conversation around kidney health, liver health, and how to actually have a long-term sustainability. So in larger populace where Black bodies and money, that's been the case since the beginning of the country, more people are going to be challenged to get things that could be more bright, shiny objects provided to get clients in, but less client education, less community improvement in health.
Thank you. And I think this is where this particular conversation comes in to provide that kind of education. Doug, coming from a GMHC perspective where that is your main function, that's your main, you know, the work that you do is focused around HIV. How do you see that this is going to impact your agency, for example, or relationships that your agency has with other community-based organizations and the people who depend on this?
I think Vaughn just made a great point. For us, it has forced us to start rethinking how we're going to restructure the services that we've been offering already. We've also are now in the process of possibly bringing on an aspect to our agency that we haven't had before. So Gmhc doesn't have a pharmacy. And now we're thinking about bringing one on, right? So looking at different ways that we can kind of make up for that deficit or make up for that issue. And then trying to identify other agencies who are doing a little better at it than we are, or have a better plan, and then trying to collaborate with them and seeing how we can kind of make this work, not just for our agency, but for all of our agencies in New York City, and then hopefully nationally. We'd like to come up with models. I think that it's really important that that's one of the things that I mentioned before, sharing information like what we're doing now is so valuable because it's almost like a think tank, right? We come up with these problems and we get together with the different experts and figure out what's the best approach. And then we engage the community members that are impacted to see what their thoughts are and if this is the best approach to work with them. So it's forced us to think, how are we going to work around this challenge right now? So
thanks, Doug. But one of the things, and I just want to acknowledge that Kenyon has shared two articles from one from NBC News that talks about health and wellness and shut us out of HIV prevention clinics embracing with Gilead reimbursement cuts, and another one from The Body talking about needlessly prescribing pricey Descovy for PrEP. But and I'm going to come back again to both Larry and Vaughn and also to Doug. How would you then see that these, you know, what do you think that on the ground in community-based organizations like yours, Larry and Vaughn, can you employ, what strategies can you then employ now with just about a month to go? Can you employ to protect your the communities that you serve? And I will expand that as well to Doug, because you're coming from a larger agency you know, what else can be done to assist and protect our community members?
I think the most important part is to ensure clients understand what their diagnosis is, what appropriate treatment protocol is, and what are the consequences of following that diagnosis. I think with all meds, we don't talk about what happens inside of our body. There's a lot of interesting information in the community, particularly since we're a diaspora. What Granny used to do to handle a symptom may not be current medical practice. We have to encourage clients to ask questions of the system and get the system to be responsive to those questions. So I'll just stick with HIV meds. Early on, New York Health Department, 2015, 2014, did a video saying it's not just HIV to encourage people to get on the treatment. They had a interesting video that scared the crap out of me. And I went to med school. I was like, so if I take HIV meds, my kidneys are gonna stop working, my bones are gonna break. They never said, here's a degree of that. And it never had a chance for community to step in. We need to make sure they're educated in a way that makes sense. This is what works for your body. This is your schedule, your understanding. Smaller agencies or mid-sized agencies need to work with larger agencies like GMHC and Cal and Lord to see if there can be a everyone wins coordination. So if I have clients that need access to the proposed pharmacy, I can send clients to the pharmacy with an understanding of this, what it's going to mean. And maybe GMHC can help support some of the infrastructure needs of an agency like GMAD so that we can make sure the community is helpful. Another example, and I guess it's kind of one of the elephants in the room, one of the largest NGOs in the world has a 340B pharmacy program. That's AHF, AIDS Healthcare Foundation, and they have mastered the ability to profit off of Black and brown bodies.
And I suggest, I think I hear that you're suggesting that they continue to exploit and profit off of Black and people of color. Larry, your thoughts on what can be done for communities on the ground there in Atlanta, and I might be too much of a stretch to think how you can talk for some of the other southern states, but some of the things there may be commonalities. Thoughts?
I think that Vaughn hit the nail on the head. I mean, as much information as possible, making sure that people know what's occurring on their behalf, behind the scenes. Nothing is more jarring than, changes in a formulary, changes in the law that impact your life, especially as a person living with HIV who's not an advocate, who doesn't work in HIV Inc. It can be very traumatizing for your meds to not be covered, for you to be hit with like a large bill, for your meds just to be changed without your knowledge. So we kind of prioritize getting people the information and hoping to inspire in them a bit of advocacy so that they, self-advocacy, you know what I mean? So I feel like that's the most that we could do on the community level. But then as people who get paid to do HIV work, I feel like we also have the responsibility of doing advocacy. You know what I mean? Really like showing up and utilizing the fact that we have the lens and the language that we have to push back on these wrong-headed actions a lot of times that happen. And, like Vaughn just did, call into the carpet, in whatever way that we have to possible, inequity, and potential harm. So just making sure that like we're demystifying our communities is the most that we could do, I feel like from our standpoint.
Thank you very much for sharing that, Larry. Doug, do you want to jump in and just quickly share with us what is GMHC doing to prepare its clients for something like this happening?
Right. So I would agree with both Vaughn and Larry in that what we're doing is a lot of education and awareness, right? Because a lot of our participants may not be aware of the changes, may not know how to work around them or navigate them. And the other thing is we do a lot of awareness around resources, right? So, Larry mentioned empowering some of our members and participants and community members to advocate for themselves, but sometimes that's not always possible. And so we also connect them with other resources that might be able to support them in that process. So.
All right, thank you. Thank you very much, Doug. I see that we've got Alex, Deacon Alex, who's calling in from Jamaica, had raised his hand. Do you want to share? Do you want to share something? Do you want to ask a question?
Yes, I basically would like to share something as well. And as we basically celebrate our World AIDS Day, these are the things that basically we need to address here in Jamaica on a basis to end the stigma of HIV and the high rate of HIV, right? We need to go forward to the move forward to the Sexual Against the Persons Act, which is 1984. We need to review each section on a day-to-day basis that persecute and suppress the LGBT community. Reason why HIV is on a high rampant here in Jamaica, because of this law, most of the LGBT community who have tested, they know that they have it, they know that they're positive, they don't want to go and seek medical treatment based on the stigma and the discrimination. You understand? So these are the things that basically we need to address here. We need to provide social mental health for the support for persons who live with HIV, and especially members who are living in the LGBT community. You understand? So these are the things, these are the conversations that we need to bring to our representative, to our elected leaders, which is our politicians, to say these things are happening to persons, and we must come to a solution or something to end these things. So it's basically the discrimination and the human rights violation of the LGBT causing the rise of HIV in Jamaica. So once we get rid of one thing, then we can get to come back HIV for the world. It can happen, and trust me, it can happen.
Thank you very much, Deacon Alex. So we are just about 2 minutes over 7 o'clock when we're supposed to end. Doug, Larry, Vaughn, Kenyon, any final thoughts or comments you want to share with us, or ask a question yourselves?
My final thought is just that we got this, you know what I mean? Like, the situation with HIV, especially, looking at the numbers and the facts is kind of daunting and maybe daunting, but you know what, I'm just affirmed looking at this beautiful panel of Black Kings and all of this amazing work that's been done on our behalf, and just all of this amazing effort that people are putting in. I have faith that we will get to the end of a lot of the disparities that we face as Black people, as long as we can continue to show up and fight. So yeah.
Thanks, Larry. Thank you very much. Vaughn, Doug, Kenyon, any final comments or thoughts?
Yeah, I will really quickly if I could. I would say that, I think in terms of the, future of HIV care and prevention, and how to pay for it. I think, there's a lot of efforts in the community that are really sort of trying to save the system as it is. And I have been arguing to people that the system as it is not enough, because we still have the disparities that we have. And so just saving the system as it is saves maybe a lot of, organizations, but we actually need more. And so, so then the question is, how do we get there? And I think fundamentally it is, I am astounded in ways that I think is frankly unconscionable that the HIV community has really not been more active around, you know, Medicare for all or other kinds of bills that actually just are trying to make sure that every person in this country has comprehensive health care, period, right? That's where we have to start. And all the data shows that actually people living with HIV who have comprehensive health care, whether Medicaid or private insurance, actually do better in their HIV outcomes than people who just have Ryan White care, right? Just the HIV portion of their healthcare taken care of. And so we just actually take that seriously. And if that means we make pharma mad, then damn it, be mad. But you know, I think we have to actually stop playing games with them, period, and speak the truth.
Thanks, Kenyon. I do support and I agree with you. Vaughn, Doug, do you guys want to jump in here for a quick minute?
Sure. I say that I think we can end the epidemic in our lifetimes, that we have come a long way. And I think it's important that we recommit ourselves to what it will take to accomplish this through prevention, through care, to advocacy. So I think it's doable. We have come a long way. There's still so much more that we need to do, but we can do it. We can do it.
Thank you. Thanks, Doug.
I'll be quick since we're over time. We need to make sure that they understand how hot a commodity we are. They use us for money. We need to make that money work for us. We need to be able to encourage a community to demand effective services, to think about their Medicaid card as a credit card. When you swipe, you have the right for services. So through client empowerment and will, whether you're negative or positive, you're a consumer, consumers' rights, and then push and do some of the things that Kenyon said. Hey, you got to pay me for what I'm worth. And if you're charging larger dollars for the substandard care, that just can't be it. We have to just move forward.
Thank you. Thank you very much, Vaughn. And I've got two acknowledgements or two comments on gratitude from Aaron. It says, thank you for this enlightening and much needed information, much appreciated. Kelvin says, many thanks, Antoine, for this space, this panel, and this conversation or solutions. Awesome job, everyone. And we just got word in from David, who says, thanks, everyone, appreciate the discussion. So with that in mind, thank you guys very much. Thank you, Vaughn, Larry, Doug, and Kenyon for a rather informative and enlightening discussion this evening. We want to be able to thank those who are assisting us with sponsorship that have joined us as part of this. We want to thank let me get this up here quickly. Yeah, we want to thank GMAD, Gmhc, Prep for All, Callan Lord, and THRIVESS. So just quickly, DBGM is a registered nonprofit dedicated to raising awareness of mental health impacting Black gay men, and by extension, LGBTQ plus people of color. This forum is part of DBGM's outreach efforts to focus attention on HIV and mental health. The organization's programs and activities include You Are Not Alone, where we saw the documentary trailer earlier, Sons, a group for gay men of color, Her, helping every woman restore, for mothers and mother-like figures in a Black gay man's life whose sons took their life, and In My Mind, LGBT people of color mental health conference. So with that, community members, just want to say thank you very much and have a good evening.
I hate these things. Can you hear me okay?
Yeah, we can hear you, Vaughn.
So it's me.
I don't know what it is you hate, but
Bye, y'all.
all right. Thank you very much.